So we have conceived this idea of a transitional process primarily for seniors, but really for anyone that's been in the hospital. And what we see particularly in that age group is they're not going to go unassisted to a gym. They're not going to go unassisted to start an exercise program. So we've conceived this wellness center where we would bring together preventive treatment and lifestyle improvement in a way that you might start in rehab, and then when your rehab's complete, you stay and become a member of this fitness center where you are medically supervised in your fitness, and you be around people like you, your age, with your exercise abilities, and so to create kind of a comfortable environment for people to recover from. One of the statistics that's startling to me is cancer survivor life expectancy. 18 years. Yeah, I mean, cancer's a chronic disease now. I mean, we've really done a phenomenal job of earlier detection, got lots of treatment tools now. So the average survival rate, all cancers now, I mean, if you get into some, it's a lot shorter, but all cancers, 18 years. But there's a psychology that occurs that, you know, maybe I don't have to take care of myself. I'm a cancer victim. I'm going to die of cancer anyway. And yet, if you're going to live another 18 years, you can do a lot to prevent reoccurrence. You can, through exercise and diet, you can do just a lot of things. So there's a whole survivor program around cancer. People that have had a heart attack. You don't necessarily have to have another heart attack. And a big component of that is exercise and weight loss and diet control. But you got to learn those things. There are behaviors you got to learn. So we've conceived this idea of a wellness center out by the hospital that would be intended to be a transition from your state of disease back to independent living with an emphasis on changing the life practices that put you in the position that you were in. This is not a drawing of what we're considering, but this is just an example of how medical office space, rehab space, exercise space, fitness gyms, all kind of in a single place. Would have dietitians to do dietary counseling, have weight loss programs, and differing levels of fitness. And you'd be required to, as part of being a member, to get a formal assessment and plan with an exercise professional. And then there's going to be clinical people there at all times as well. And some of the things that we've looked at, I've kind of mentioned them here. And it really is this idea. You start with clinical, you go through a transitional phase of care, and then you're in a wellness phase of managing your health with the assistance of professionals. And we've looked. There's not a lot of these out there yet. They're starting to crop up. Closest one that I've looked at is Winchester. They have one on their campus.
So this is not preventive, it's rehab.
Well, it's beyond rehab, because rehab is a very clinical, restrictive kind of process.
It's getting you better.
But it's getting you better than you were before you got sick. The idea that what we see, and I sort of, you know, my poor mother, I mean, I've designed delivery systems around her care for years and years and years. But I saw her after she had her first major health incident. She didn't recover the level of activity that she had before that incident for fear of overexertion, because she had a heart attack. And that's just wrong. I mean, we can do better than that. We can do better than that. And you know, we all know weight loss is not easy. Fitness is not easy. And it's a science. And if we can link people with experts, we think we can move them down the line. We recognize that it's, you know, to make it work, it's an expense that people don't have in their life now. And so, you know, it's interesting doing the evaluation. You really look at discretionary household spending more than you look at disease patterns or whatnot. And what they're telling us is these things kind of compete for the same dollars that people spend to go to the movies or other forms of entertainment. And that the successful ones have done what Starbucks did in the urban area. They become the third place in people's lives. So, you know, you got home and you got work, and then this concept of a third place. And we haven't decided to move forward with it yet. We're still doing the research on it, but hope to make a decision later this year.
I'm concerned that this is not a preventative component to it.
Well,
So
it's
you
gonna
don't
have-
get to the hospital.
Well, you could come straight to it. No, maybe I misrepresented that. We would readily accept someone that would go through the assessment and planning program and then enroll, yes. If you're already exercising and you got a relationship with the Y or one of those, we don't expect you to come here because this is going to have more resources, it's going to cost more than the Y. So, and then the other thing we have to figure out is how do we create a scholarship fund and all of that so that we can manage access to the thing. Our goal would be to get as many of the real high resource consuming folk in there to minimize their future resource consumption if we can. So we'll see, more to come on that. I've prattled on a bit. I promised that I would only talk for a half hour and I've been at it for 45 minutes, so I'll stop, only 15 minutes over, and see if you got any questions.
Did you say they have a fee on this when the person enrolled?
Yeah, well, you become a member, so part of the membership fee would include this enrollment and assessment and exercise plan, if you will, process. So everyone would, as part of being a member, you'd see a trainer on a regular basis.
Question I've been asking for about 15 years. I started asking 15 years ago. And at that time I said something to the effect of, I am 55 years old. And I've just listened to this lecture at that time. I've listened to a lecture about the tremendous addition to healthcare that fat people are to health expenses. And I said, my father he quit smoking, he exercised everything, he lived to be 96. He died anyway. He died his last 3 years or so in a nursing home. But during that 96, between 66 and 96, he collected 30 years worth of government pension and Social Security. Why was it cheaper for him to live to be 96 than for him to have died when he was 64?
We can isolate an individual and tell a story that seems counterintuitive.
Well,
but you asked now, and I'm going to give you an answer. When you scale it up to a social level, so now you're talking about tens of thousands or hundreds of thousands of people, obesity drives disease processes earlier. So if you're 70 the first time you get a serious illness, you may only have one serious illness before your life ends. If you're 30 when you have your first open heart surgery, then you're going to go on to get cancer and you're going to go on to get other diseases. And your life expectancy statistically will drop dramatically. The average life expectancy is driven by a lot of factors. Obesity is one, household income levels, and others. Yeah. The life expectancy in the zip codes that make up West Baltimore today is 62 years old.
Which means very little money goes out on them in Social Security pensions.
Well, but let me comment on that. I'm not sure our society is in the accounting game, right? I think aren't we trying to preserve a way of life and a quality of life that is unique in the world, or at least unique as far as the world I've seen so far. And we're trying to do that for everybody. So we kind of think in terms of macro statistics. So, you know, great joy for your father that made it to 90. And I hope he was active and every day was rich and full of experience for him. And I hope I make it to 90, and I hope you make it to 90. But statistically, some of us in this room aren't going to make it to 90. And so how much resource are we going to consume during that period of time? Nothing would make me happier than to look back in 40 years and say, geez, I'm 98, and that Obamacare really changed society. Look how many of us are still around at 98. You know, that would be a wonderful thing. And will it cost society more? Maybe. Maybe. But we don't do healthcare for the money. I'm not an accountant. I had no formal financial training. I became a hospital administrator because I had an aunt that was a nurse and a father that said was an engineer. And my father said, you know, he said, you're really not the engineering type. And so the only other reference point I had was my Aunt Joanne that was a nurse. And she said, you're really not the nursing type. But you know, the guys that run the hospital wear nice clothes. Maybe you ought to look into that. And that's how I became a hospital administrator. So I hear that argument that let them have the lifestyle they want, they'll die off and it'll be cheaper for society. I'm not signing up for that plan. That's not why I'm here. It's not why I run your hospital. I want you to have the richest, most active life you possibly can, as free of health challenges as we can possibly help you get to. I just want to make it an inexpensive lifestyle if I can. And so that's where I come down. That's my answer.
If you let me, we'll talk later.
Okay.
I'm not sure. Are you seeing the insurance carriers, how they're responding to this? And as small business or business folks, are they forcing folks into the exchange more than expected?
You know, I think it's early, but one of the things that's forcing some people into the exchange is there's a lot of non-compliant policies out there, and that's that tens of thousands of policies being canceled this week. In Maryland, so far, the payers are behaving pretty darn rationally. So Blue Cross led the charge, and they have a full slate of products on the exchange. United has a full slate of products on the exchange. Aetna, we don't know what they're going to do yet. Cigna, we don't know what they're going to do yet. But it looks like they're going to go on the exchange. So I think, at least here at home, they're behaving pretty darn rationally. We've got to make some decisions with the Medicaid MCO, because if you think about it, there's a population that's going to move back and forth between Medicaid and the exchange. And we think we're going to have an exchange product, not the first year, but the second year, just so those people don't go through the extreme stress of changing coverage, because it's stressful to change coverage. So if we can figure out how to do that in a way that's seamless for that consumer population, we'll probably do that.
How do you see churches getting involved in wellness programs for the elderly and for children and other pieces of the population? What can we do to help the wellness end of things?
May I speak to that? I have a meeting tomorrow morning with Wendy Zimmerman, who's somebody you may know, and Cindy Earle, who sort of helps community education. And what we're hoping to do is to talk about some wellness programs that possibly we could run through churches, where the peer support group, the theory of it, that the peer support of a congregation, maybe led by the pastor, would encourage people to participate and lead healthier lifestyles. So if you can be patient, maybe in another month we'll have something to share with you as far as an idea. But that's in the works, and Mary Ritz was a part of that. We were talking about that last June already. And so we're even thinking of maybe trying to pilot it down in West Virginia too, with some churches down there. But we'd like to try to start it here in Hagerstown.
Well, I can give you a couple of examples of programs I've seen. One of them, first, you can overwhelm them if you come at them with, diet and exercise, but, you know,